Mr. Shed.
Hi, good morning. Welcome to day two. The next talk is even more interesting, and we are worried. So it's about seizures and stroke mimics, and it's going to be done by Dr. Yaseen Yacoob. Is he? Oh, excellent. And then it's going to be, he's a neurologist from Limerick, and his special interests are, he has done a lot of work. He's currently based in Limerick, but his interests are epilepsy and HIV. And I hand over the stage to you.
Thank you, Margaret, and Bias for inviting me to speak today. I don't know that this is going to be more interesting than the previous talk. So anyway, I'll get on with it. There's two parts of my talk today: seizures as a stroke mimic. And the second part would be post-stroke seizures. So let's run through some basic definitions. What is a seizure? A seizure is an abnormal, excessive, or synchronous neuronal activity in the brain. Epilepsy is a disease, a disorder, where you are, or one is, more susceptible to having recurrent, unprovoked seizures. So at least, and by the International League Against Epilepsy, the definition thereof is at least two unprovoked seizures occurring greater than 24 hours apart, or one unprovoked seizure, and the same risk as someone who's had two unprovoked seizures, and if one has an epilepsy syndrome. Seizures occurring as a stroke mimic it accounts for 1 in 5 patients, up to 1 in 5 patients. And it's important to differentiate seizures from stroke and to timeously institute the appropriate therapy. So when we look at various stroke mimics, we see that seizures account for most of the presentations to the ED as a mimic or a masquerader of stroke. And this is followed by syncope, functional neurological disorders, primarily headache disorders, migraine, aura. So how does a seizure mimic a stroke? It's usually due to the negative symptoms that are associated with a seizure, and it's usually post-ictally. When I say negative symptoms, if we look at positive symptoms as being jerks or convulsions or tonic-clonic movements, I refer to the paralysis or weakness that one notices post-seizure. And this is due to cortical neuronal exhaustion, substrate depletion, or hypoxia. It's postulated that these are the causes. And the term Todd's paresis has been coined for weakness that's associated with one of these, with this phenomenon, but the presentation goes well beyond just weakness, and one can get language disturbances, oculomotor function disturbances, somatosensory disturbances, consciousness, and visual field disturbances. And so the term Todd's paresis is probably better described as Todd's palsy, and this was named after Robert Bentley Todd, who was born in Dublin in 1809 and died he was born in Dublin, and he then went across, he studied at Trinity College, went across, studied at Oxford, neurophysiologist, and then worked at King's Cross Hospital in London. And apart from having the Todd's palsy, being accredited with that, there's something else that some have accredited with, and that's the hot toddy. But apparently he prescribed this to his patients, a concoction of brandy, cinnamon, lemon, and a syrup. if you know, you know, it seems. Seizures can present in a myriad of ways, and having a cursory knowledge of the basic anatomy of cortical structures is important. And this slide describes some of the areas of the brain and their function, and knowing that the visual cortex is in the occipital lobe, and seizures can present with flashing lights, bright lights, or just loss of vision. And along the medial cortex here is the motor strip for the lower limbs. So you could have pure lower limb tonic movements, clonic movements associated with a seizure if that strip of motor cortex is affected. But most commonly, it's the middle cerebral artery distribution that causes seizures. And having a basic knowledge of some of the areas involved, including Broca's area, where one could get a language disturbance and not being able to express oneself, or the motor strip, where one could get a Jacksonian march, where you start with a little area of twitching or jerking, and it could spread to further areas. So it could start in your thumb and then progress to the arm and then the face. That would be a suggestion of a seizure. And this important area anterior to that is the frontal eye field, and that controls conjugate gaze on one side or to one side or the other, and we'll go through that shortly. So when do you suspect a seizure in an individual? If someone has a prior history of seizures or epilepsy, I would suspect a seizure. Impaired consciousness or a vague patient who presents with jerks, either tonic, clonic, myoclonic, that are either associated with weakness or just prior to the weakness. If there's worsening deficits in the same region of a prior stroke, so patients had weakness on the right side because of a stroke in the left cortex, and then presents to hospital with worsening weakness in the same side, have an index of suspicion of a stroke, of a seizure. If there's rapid improvement, and this is probably one of the key things that would help differentiate a seizure from a stroke. Within minutes, patients with seizures usually improve, as much as the definitions of Todd's paresis occurs. It could be up to 24 hours, etc. But seizures, by and large, improves within minutes. The weakness associated with it, at least, improves within a few minutes. And then there's certain eye signs which we'll discuss in the next slide. And one of the key, important things that we should consider is the frontal eye field, which I had alluded to previously. This frontal eye field sends a message to the opposite pons to tell your lateral rectus on the right, so the right lateral rectus, and your left medial rectus to move both eyes to the right side. Anatomy 101. And that's, press that button, and both eyes move to the right. In the setting of a stroke, in that region, what can happen is you can't get, this pathway is affected. And so in the extreme case, you may get a gaze palsy to the right. Or you may just not be able to move it as well to the right. It might be central, but you can't get the eyes off to the right. But in the extreme case, you can just get deviation of the eyes to the left, which is to the side of the lesion, away from the weakness. Now, consider, if you will, repeatedly exciting this pathway, as in a seizure. What you do is cause the eyes to move in the same direction as the weakness. And that's one of the subtle ways of differentiating a seizure from a cortical origin, from a stroke. And obviously, if there's a brain stem stroke, then this goes out the window. And my colleague Simon Cronin might allude to it in his talk later. Right. So I'll go to a case whose a patient is still in the high care. I've just seen him 2 days ago. His clinical his name was as intriguing as his clinical presentation, and he says I can use his name in the presentation. He's Mr. Adamkiewicz, and no, he didn't have a spinal cord infarct. That would have been uncanny. But Mr. Adamkiewicz is a 68-year-old gentleman. He has a background history of a cerebral aneurysm, coiling and clipping, 2 separate aneurysms, and he presented as a fast positive. He presented with left hemiplegia, and this was preceded by jerks on the left side, and he was noted to be confused. This is a video that I've taken of Mr. Adamkiewicz. He's got left hemiplegia. Lift your arm up, Anthony.
Oh, that's
lift it up. Can you lift your arm up? But notice his eyes are going to the side of the weakness, which is unusual for a stroke. It would be the opposite side.
Lift your arm up, lift this arm up, lift it up, give my fingers a squeeze.
So he does
Squeeze
it on the
it
right
tight.
side. He's intermittently
Good man.
aware,
What about the left arm? Are you able to move that at all?
and he didn't move the left arm, even by further prompting. So we investigated him further, and lo and behold, he had ongoing seizure activity on the right side of his brain. A few days later, actually he had quite a protracted course. We had to intubate, ventilate him, and use significant doses of anesthetic agents to control his seizures eventually. And
Up for me. Yeah. And back down.
yeah,
Okay. Look to your right.
yeah,
Look to your left.
yeah,
Look straight ahead.
yeah,
And arms up again. Arms up. Lift your arms up again.
yeah.
And down.
Okay, so that's Mr. Adamkiewicz making a good recovery from seizures. So his MRI scan showed no acute stroke, and he just had the clipping of the artifact associated with clipping of his aneurysm in that region. So I would say seizure at onset, however, is not a contraindication to thrombolysis, right? And when you're in doubt, thrombolyze the patient. There are certain chameleons that we should take into account. That's strokes that masquerade as seizures, and a limb shaking TIA with critical carotid stenosis is one such chameleon, but it's more posture related jerky movement. So stand up, reduce your perfusion to the brain, and your arm starts shaking, jerking, and get back into the recumbent position, and it may settle. Hemichorea, hemibilismus, and hemiparkinsonism in the setting of a stroke can look like a seizure sometimes, and brainstem ischemia can sometimes present with chronic tonic movements, and this is due to ischemia to the tracts that are going down as opposed to cortical ischemia. So, second part of the talk, which is post-stroke seizures. Post-stroke seizures, or seizures in relation to stroke, are classified according to whether it's an acute, symptomatic, or provoked or early seizure, or a late, unprovoked seizure, which is actually epilepsy if it's late and unprovoked. Whilst the classification is time-based by virtue of its temporal association with the stroke, it's actually the underlying reason behind it is the different pathogenetic mechanisms that trigger the seizures in the initial 7 days as opposed to the days beyond that. And the risk of having a second seizure after the first seizure in the acute setting is much lower in the first 7 days as opposed to seizures that are occurring beyond this period. And this has implications for treatment. So why is it important to know about or to treat post-stroke seizures? They're associated with high mortality, poorer functional outcome, greater disability, and increased dementia risk. So why do patients with stroke develop seizures? The mechanisms involved include, in the acute setting, in the early seizures, include loss of neurovascular integrity, blood-brain barrier dysfunction, neurotransmitter release, ion channel dysfunction, whereas those in the later unprovoked group are thought to be due to chronic inflammation, gliosis, angiogenesis, neurodegeneration, neuronal sprouting, and plasticity. And if one has a drug that could work at that level, you could potentially prevent seizures in these patients. So as I discussed, the risk of a stroke in the early phase, in the provoked phase, is much lower than the risk in the later phase. And the sort of arbitrary cutoff of 60% risk when one would choose to treat is not met with the early seizure. So not all patients with a stroke develop seizures. What are the risk factors? So the initial stroke severity or stroke type, so a high NIHS stroke score, a hemorrhagic stroke as opposed to an ischemic stroke, the location of the stroke, whether it's cortical, and if so, an MCA distribution. A younger patient below 65 is at higher risk. And if there's certain EEG abnormalities in the acute phase, that would render one more at risk of having a stroke, including periodic lateralizing discharges. Patients can present in various ways. The commonest is a focal onset with secondary generalized tonic-clonic. You could have focal onset with impaired awareness, focal onset without impaired awareness, or a generalized tonic-clonic onset, or generalized onset from the beginning, or one just doesn't know the onset. The signs can also be subtle, and that's another key thing. You could have focal intermittent eye deviation or nystagmus, mild facial twitching, focal sensory changes, worsening of the existing motor deficits, and impaired speech. In terms of investigations, I've deliberately not included CT perfusion as it's not an exact science at the moment in terms of in terms of its utilization for seizures, because the CT perfusion in the acute setting during a seizure may show hyperperfusion, but you catch it after the seizure and it'll show hypoperfusion. So it really, you can't. It's not definitive at this stage. The MRI scan is an important modality. It's usually normal in a seizure, but in a stroke you'll get diffusion-weighted abnormalities. But if you do get diffusion-weighted abnormalities in a seizure, and which you do, it's usually reversible, it's not in a vascular territory, and other remote areas can light up, such as the thalamus and the hippocampus. So that's important to understand in terms of differentiating. The EEG can show certain patterns, such as periodic lateralizing discharges, bilateral periodic lateralizing discharges, theta wave discharges in the temporal lobe, and these would suggest seizures. So when do you start anti-seizure drugs? Because it's similar to the antidepressants, should everyone who has had a stroke in the cortical distribution be put on an anti-seizure drug? Should we institute primary prevention? So randomized controlled trials have looked at this, and they found that there's no benefit of putting everyone onto a anti-seizure drug. ESO guidelines do not recommend this, and the only primary preventative drug that has been shown or a category that has been shown to be of benefit are statins. In terms of secondary prevention of stroke, so those patients who've had a stroke in the acute setting in the first 7 days, should we treat those patients? Should we start an anti-epileptic drug on someone who's had a seizure in the first 7 days? According to the guidelines, no. According to clinical practice, almost always. And that's the case even in our setting. So there's a way to categorize patients as to having a higher risk of having seizures as opposed to others. And in the setting of hemorrhage, the CAVE score has been suggested, where one looks at the cortical involvement, the age of the patient under 65, volume of greater than 10 mils, and an early seizure, allotting 1 point each, and 4 points confers a 46% 5-year risk of seizures. And perhaps more important and useful is the SELECT score in an ischemic stroke. And here one looks at the severity of stroke according to the NIHS scale, with a score of 2 if you have an NIHS of greater than 11, whether there's a large artery atherosclerosis, whether one has had an early seizure in the first 7 days, and whether one has cortical involvement, or is it the territory of the MCA. And if one scores patients, one would see that a score of 8 to 9 confers a 65% or 83% 5-year risk of having a recurrent seizure. And that would, one could then choose who you'd put onto treatment or not. And, you can have a discussion with the patient as to, look, this is your risk. And a useful tool is the SELECT score tool. It's on the App Store, whether it's on Play or Apple, and it's simple. It's just a 5-point yes/no click of a button, and you can calculate the person's 5-year risk, 1 year, 2 year, 5-year risk. It's a little bar that you could move, looking at whether it's a 1-year risk, 2-year risk, 5-year risk, and you can have that discussion with the patient. Okay. So what if a patient has had multiple seizures in the first 24 to 48 hours in that early phase? I'd put them onto an anti-seizure drug, because it has been shown in certain animal models that it improves recurrence, or improves, not only that, it improves stroke rehabilitation and recovery from the stroke as well. There's not strong enough evidence for this, but one would treat patients for about a month to up to 3 months. What if post-stroke seizures would state as epilepsy in the initial phase? Studies have shown that this increases the chances of later seizures, and so you'd stick everyone onto anti-seizure drugs. What if an EEG shows periodic discharges in that early phase? I'd treat the patients in this case. So when we choose to treat the patient, what should we choose? There's so many drugs out there. There's the older generation anti-epileptics before 1972, and there's the newer generation. So what should we choose? And so this is dependent on a host of factors. Patient factors, age, gender, comorbidities, and medication factors, the efficacy of the drug, the tolerability of the drug, interactions, and most of the patients on polypharmacy. So one of the key things in the age group of patients who are having strokes is the interactions with other drugs and the comorbidities. And so I'd just stress on that. The older anti-seizure medications, phenytoin, carbamazepine, phenobarbital, oxcarbazepine, they induce the cytochrome P450 system, leading to faster metabolism and reduced efficacy of many of the cardiovascular and anticoagulant drugs. And this would result in reduced warfarin, reduced statins efficacy, theoretical, reduced clopidogrel, reduced antihypertensive, and increased the risk of osteoporosis. And therefore, there's a clinical concern of recurrence of strokes in this group. Valproic acid is an inhibitor of these enzymes, and hence the total opposite. You have an increased risk of hemorrhage. Phenytoin in combination of valproic acid compete for protein binding, and this tends to increase the free drug levels, and one can get toxicity. And lamotrigine and valproic acid, the interaction is such that valproic acid inhibits lamotrigine metabolism, increasing lamotrigine toxicity, and therefore you'd have to be very mindful of this. So in this network meta-analysis, it's just on preprint at the moment in neurology, they looked at over 18,000 patients who've had post-stroke seizures and were put on an anti-epileptic, and they compared patients to levetiracetam. And they looked at 4 outcome measures: seizure recurrence, adverse events, dropout or cessation of the drug, and mortality. And what they found was that SD-carbazepine, lacosamide, and lamotrigine fared very well when compared to levetiracetam in terms of seizure recurrence. The adverse events was the worst with phenytoin. In terms of discontinuation of the drugs, zonisamide, phenytoin had the highest discontinuation rates, and mortality was the highest in phenytoin. So, in summary, levetiracetam, lacosamide, lamotrigine, fewer drug interactions, better tolerability, better choices. Phenytoin, carbamazepine, phenobarb reduce anticoagulant and statin effectiveness, higher stroke risk, and poorer tolerability. Valproic acid increases anticoagulant effects, and therefore you have a bleeding risk. Lamotrigine and valproic acid, there's a risk of drug accumulation and toxicity. So that is a basic summary of the anti-seizure medication. The principles: start with monotherapy, start low, titrate up. If seizure recurs, you increase the dose accordingly, and then, if needed, add a second drug. And and when choosing the second drug, try and choose a drug with different mechanism of action. I think there's a separate talk on driving, but essentially, provoked seizures do not incur any specific restriction if it's a provoked seizure. Late seizures, usually, we put patients out for a 1-year period, 6 months or 1 year, depending on that. Take-home messages: look out for seizures as a common stroke mimic. Identify clues on history and exam that may suggest a seizure over a stroke. Early and late seizures have different pathogenetic mechanisms and different recurrence rates. Use the SELECT tool to stratify seizure risk in ischemic stroke. Treat all late onset seizures and certain high risk early seizures. Levetiracetam, lacosamide, lamotrigine are overall good first choice drugs, and try and avoid enzyme inducing anti-epileptic drugs. Thank you.